this is again another, you cannot say it's a presentation, it's just a method that we developed in our clinic. Most of the things that I'm presenting here, I brought them with the thing in mind that these should help newcomers who are just starting up. So when we started and I had my residents, so I had these same problems, how to communicate to them and pass on the skills to them, and in a little bit systematic way, so that they can master the same amount of aesthetics and finesse that we achieve after years of practice. So similarly, the hair sorting according to diameter and recipient side staining, although I used to do it without all these tools, but to pass on these skills to your newcomers, you need to develop a little bit of formalized system so that you can measure their progress, and you can just put a quality control system so that you can see that whether the same qualities or same values are being given to the patients by your residents also. So one of the main things is balancing the hairline. So there are two parts of the hairline. One is the irregularity that you need to create to give a undetectable look, and the other thing is that it should be balanced also when you see it from the front. So there are multiple methods and tricks and tips to balance the hairline. Plastic surgeons use different techniques, dermatologists use different techniques, and every hair transplant surgeon uses different techniques. And every technique has its own value, and it depends with which technique one is comfortable with. But a surgeon who is just entering the field of hair transplant, this is something I felt very easy to communicate to him, because I saw a lot of hairlines in my practice which were not actually balanced. One side was a little higher, the other side was a little too lower, and some people use eyebrows to balance that. But what we noticed in our practice, the eyebrows sometimes are very imbalanced. One eyebrow is upwards, maybe there is sometimes there is a difference of even 1 centimeter in two eyebrows. The left eyebrow is sometimes lower. So this is how we just do it to make a totally balanced hairline. We just put a central mark in the center above the glabella, then we extend it to the point where we want to place the anterior most part of the hairline. Then we just put another horizontal line above one eyebrow, and then we place another third line on the second eyebrow. And we use a foot rule just to balance these two, and these two lines can even pick up the difference in the eyebrow level also. Then we connect them. Then almost 5 centimeters from the center, we mark 2 points, one on the right and one on the left. 5 centimeters is not specific, but what I realized during these 10 years is that 5 centimeters is something which gives you proper control in balancing the hairline. Because if you're less than this, like 4 centimeters, you will have imbalance just at the frontotemporal angles. And if you are too wide, then the central part may just get swayed away to the right or left. Then we, at the 5 centimeter point, we extend it to the anterior part of the hairline where we are going to take our frontotemporal angle, and then we connect this like this. So in this way, you can actually measure the hairline from both sides, the left and the right, and you can see whether both the sides are at the same level. We call it the X point and the Y point, and X should be equal to Y. And plus, the loopholes in this technique are that you have to make sure that this plus line, the vertical and the horizontal line, they have to be at right angles to each other on both sides, on the right and the left, which is very easy to maneuver with 2 foot rulers if you are using disposable foot rulers. This is how we do it on a practical patient. From the right side, from the left side. And this is how we just establish the horizontal plane. Then we measure 5 centimeters, then measure the total, 5 centimeters on the left and 5 centimeters on the right. Then we measure the vertical length from both sides. The both vertical lengths should be same. So you are dead sure about that your hairline is balanced from both eyebrows. Then we measure it from the center also. And in this way you can just pass on the art of balancing the hairline to any newcomer, and you can put a control on that also, that he can himself measure both sides. Most of the techniques which are being used are by masters of the industry. So they are good at it, they don't need to measure it. This is something which a newcomer should focus on. And it's very important because the main thing when a newcomer comes in, he forgets to balance the hairline, and sometimes the hairline is just deviating to the right and to the left. Thank you.
Basically, we are having a lot of pain scales. We use this Wong-Baker Faces pain scale. It starts from 0 to 5, and it's easy to use in all sort of patients. The objective was to compare the pain level between the supraorbital supratracheal nerve block with the subcutaneous injection in hair transplant surgery. Before going for the nerve blocks, the anatomy, surgical anatomy of the supraorbital and supratracheal nerve blocks of supraorbital and supratracheal nerves is important. In mostly, the supraorbital nerve exits from the supraorbital foramen, which is about 27 centimeter from the midline, and about 10 millimeter, it is the supratracheal nerve exits from the. This is our injection technique. We basically use this superior techniques of nerve blocks. Basically, there are two techniques. One is the anterior technique. We give the local anesthesia from the anterior side, and the second is the superior technique. And basically, this is the. I will just. So this is a nerve block technique which we have been using 3 ml of local anesthesia, injecting about 1 ml in the midline, 1 ml on the right side, and 1 ml on the left side. And the injection is given very slowly. In this study, we compared the pain levels. We injected 3 ml of local anesthesia on the left side, and on the right side, we used 1 ml wheel of local anesthesia and started from midline, and then we progressed towards the temporal sides. We included 15 patients, and all those were having the first session of hair transplant. The mean age was 35 years. So we were using this nerve block. This is the pain level. The average pain level in nerve blocks was 1.93 as compared to the pain level of 3.53 in subcutaneous injections. That means the subcutaneous injections were more painful. %60 were the non-smokers and 40% were the smokers. And another observation which we had during the surgery was in nerve blocks, smokers had a mean pain scale of 3.3 as compared to the 1.89 in non-smokers. Similarly, in subcutaneous injections, smokers had 3.8 compared to the 2.0. Now, the observations we concluded from this study, the first couple of injections on the sides having nerve block were painful. That is basically due to the variation of nerve branching. And the pain has basically two components, the superficial and the deep. The superficial component is basically due to the direct needle prick. And we can avoid this superficial part of pain by using the topical anesthetics. The deep part of the pain is basically due to the actual distension of the local tissues by fluids, and this part of the pain can be minimized by injecting very slowly. So the conclusion was this nerve block is is a useful technique to decrease the severity of the pain, and every effort should be made to make the patients as pain-free. Thank you.
I'm going to talk about type 6-7 male pattern baldness, which is actually a challenge if we are talking about hair transplant only. I'm not talking about the patients where I'll do the front part with the hair transplant and cover the rest with the hair piece. We have seen, we were discussing earlier about the pattern of losses and how many people get bald by the age of 80. Generally, male pattern baldness by itself is about 65% in the population, and the rest could be according to the, you know, as you grow, you tend to lose hair. Sorry. So this is the male pattern baldness that we're going to talk about. I have got nothing to disclose that have got any conflict of interest. Now, as we heard earlier, hair transplant surgeons are like illusionists. They are trying to create an illusion with a 30% of the available donor area and to cover 70% of the recipient area, and of these 30% you can take only 25%. So we are actually talking about covering the entire 70% with the mere 10% of the actual donor area. So you really need to play around with everything, and of course it would look nice if you see it from this view with about 4,000 grafts, but generally if you see the back portion, there is a lot to be covered over here. So that means that you need to understand how you're going to distribute your grafts, and at the same time you have to tell the patient that, look, this is type of the this is what you would look like. So we have got about 800 square centimeters, and if you see this slide, it will tell you with a normal density, this is undetectable hair loss. That means you are losing hair, but you are not knowing that you are losing hair. It's not visible unless you cross the watershed line of about 50%. As soon as you go beyond that hair loss, it is visible. The hair loss is visible, and then from 50% or about 50 follicle units per square centimeter, you go down to 20-25 follicle units per square centimeters. That is when the second threshold comes and you become significantly less. So keep this 20-25% like that, and this is where I personally think that doing extensive density, I mean, why would you do that 50-60 hair grafts per follicle unit unless you're going to cover the rest of it with some sort of hair toupee or something like that. But generally in my practice, you should not go beyond 30. If you cover 30, you are somewhere around here, which is a decent coverage. It's not dense, but you can cover a lot more area with the rest of it. So this is what we get. We get a lot of baldness over here, but this is like Ludwig types of hair loss. You have got a mid scalp area to be done, and you have got the whole of the crown to be handled. Plus you have got this area of temporal points, which is again important. Again, donor area is actually not equal to the recipient area. You have got far less donor area available than what your recipient area needs. In type 7 hair loss, we have got about 475 square centimeters to 525 square centimeter hair loss, and donor area is 275 to 325, and of this, mind you, the visible donor area is 40% of the visible donor area of about 100 square centimeters. So this is all you can actually do. So that means you cannot do more than that. So this is, if we see this person, this is the thinning area, this is the thinning area, and this is the true donor area, where you can actually take a nice decent number of grafts up to 4,000, 5,000, and unless I'm not sure that I would have minimum of 5,000 grafts to 6,000 grafts, I would not do the surgery unless the patient agrees that all he will have is a little hair over there, which will give him some sort of self-satisfaction. And then again, you need to understand that you cannot go beyond that, you cannot go below that. If you go beyond or below that, you are risking the hair loss in the future from there. Again, you need to understand where your donor area is. If you are doing a strip method, and also the donor area that you can go if you are doing a follicle unit extraction. Once again, coming back to the same thing, planning. Planning is half winning the war. So if you plan well with the limited donor area, the coverage the patient demand can become a problem. So planning is vital, and so is patient's education and expectations. A viable donor area of at least 6,000 to 7,000, as I said earlier, before you embark on this journey. You need to understand that in this type of patient, this is the only class you should do. If you have got anything like this, please do not go towards that patient. Now this gentleman who has got type 7 male pattern baldness has got a lot to cover. So you would plan, and how would you plan? You basically go, you see what areas you want to cover, you discuss with the patient that look, these are the areas that I'm going to cover. And what I do, I basically go from type 7, I'll first make the humps, from the humps I will cover little area, from the little area I'll cover this area, and as I go this I can see where I can go. So probably come to the occipital or the crown area at the very end. If I can cover, that usually would be the 4th session. Now in my practice, I am not a fan of one-stage surgery, because if I am planting 4,000, let's say if I can take 5,000 grafts in one session, I'll still not do it in one session. The reason being is, in my own practice, I've seen that if I transplant 4,000 grafts in one session and 4,000 grafts in 2 sessions, either 2 equally divided or one bigger session, one small session, my outcome of the grafts is the same by my elution, but my elution is about 25% better. So all my patients go through at least 2 stages of hair transplant restoration. I am not one stage person. So what I'll do is that I'll first create the humps, as I said earlier. I'll try to point out where the frontal point that I'm going to display. I'll make sure that it is not too low. I do not try to go less than 7.5 centimeters. Initially I used to be at 7 centimeters. I've moved up by about half a centimeter, and that is where I stick to. The second step is to place the hair in the line which way it needs to be. You know, when you are dealing with a thinner